Welcome to Envision More. Here, we dig deep into the insights of first-generation wealth builders, unearthing stories of passion, resilience, and relentless vision. Your host is Wayne Wagner Jr., founder of Vizionary Wealth Management. So sit back and dig in. It's time to envision more.
Hey, this is Wayne Wagner, and welcome to another episode of Envision More, the podcast. Today, we are going to be talking about all things Medicare. I've got Jason Lamadou, president of Nexus Insurance Advisors, with us. Jason and I did a webinar some time ago that was really well received by our clients. We wanted to bring him back to do a quick primer on Medicare coverages, but also to dig into some stuff today because there's a lot of change coming in the Medicare world, and we want to dig into that a little bit with Jason today. So, Jason, thanks so much for being here.
Hey, Wayne. Yeah, thanks for having me here. I'm very excited. I know everyone, all of your listeners, they're probably very excited to talk about Medicare for the next half hour or so.
Yeah. So, waiting with bated breath, I'm sure. So,
yeah.
And this is, and listen, this is something that, as I've discovered, really from listening to you and learning from you, is that when you're coming up on age 65, about 6 months before you turn 65, you got to sit down with somebody. You got to have a conversation, or you're going to spend an inordinate amount of time trying to learn this stuff on your own and learn what the options and solutions out there are and how those solutions meet your actual needs.
Yeah.
You can
Wayne,
cut the amount of you can cut the amount of time of your own time that gets invested by bringing in an expert to help you and support you with it. My understanding is that you don't. So, Jason, the insurance companies compensate you, so you really don't, and the compensation is really standardized. So it's really do the right thing for the client, and the client's not paying anything different out of pocket other than what they really should be spending and need to spend. So,
correct. Yep, absolutely. The plans cost the same whether they get help from us or they try to do it themselves. And unfortunately, Wayne, as I'm sure a lot of your clients know, that when you're approaching 65, you really don't get a lot of guidance from the government, right? So you get this 130-page handbook called Medicare and You, and they basically say, here you go, good luck, and if you do it wrong, penalties forever.
Right.
So
Right.
that's where it's definitely beneficial to sit down with somebody to discuss these things.
Yeah. So today, what we want to do is do kind of a primer and review on kind of the different pieces of Medicare. And we're going to spend 10 or 15 minutes doing that. And then we want to dive into some of the big unknowns, because you've kind of terrified me, because I'm looking at, I don't want to turn 65 next year. I'm a few years off from that. But like, based on the amount of change you have suggested is coming to this space, I'd be concerned if I was 65 or over and trying to navigate this on my own. So I want to spend some time for our listeners trying to provide some education and some perspective on that. But let's why don't we start with Medicare 101? I'm going to turn, let's just say I'm going to turn 65 in 6 months. Jason, my advisor, Wayne Wagner, told me I'm supposed to call you. Like, where do we start? What do we do? What do we start with here?
Yeah, I appreciate it. So, the first question really is, what is your current situation? What is your current coverage, right? So if you work for a bigger company and you have what's called creditable coverage through your employer, you can delay enrolling in Medicare, right? So that would be the first question. Do you have creditable coverage through your employer? If you do, then there's a certain way we'd go. If you don't, then you have to enroll in Medicare, 3 months before the month you turn 65. We would have Medicare start the month of your birth month. But, there's really a couple. So that's where we would start. And there's 3 different things you could really do when you're turning 65. So the first thing would be do nothing. The second thing would be sign up for Part A and delay everything else. And then the third would be sign up for Part A and B and everything else. So the person who would want to do nothing, that is the person that has creditable coverage through work. And they also have what's called an HSA, a health savings account with a high deductible. And the reason being, you don't want to sign up for Part A in that situation, because if you or your employer makes any contributions to the HSA while you're enrolled in any part of Medicare, then there would be tax penalties
Hmm.
associated with it. So that would be the person who does nothing is the person who has creditable coverage from work, and it's an HSA with a high deductible account.
Now, I talked about penalties. We talked about penalties. If I'm in that situation, so I have creditable coverage
Hmm.
and I have an HSA, and is it creditable coverage and an HSA or creditable coverage or an HSA?
And
And so it's
that
a both
situation is
and.
and.
Okay.
Mhm.
So now in that situation, I'm not going to automatically enroll in Medicare at age 65. Are there penalties on my future Medicare premiums because I didn't do anything at age 65?
There are not, as long as it is creditable coverage. Now, your
Okay.
employer, by law, they have to give you documentation stating that your coverage is creditable. Because
Okay.
you're right, Wayne, if you do delay enrolling and you did not have creditable coverage, then you would be penalized.
Right. And those penalties, A, last for the rest of your life,
Hmm.
and B, they can be really significant.
Correct. Correct.
Right.
Yep. So for your Part B, for example, and we'll get into what Part B covers in a little bit.
Sure.
But if you were eligible for Medicare Part B, you didn't have the work, the creditable work coverage, then they would take every year that you should have been enrolled in Medicare and you weren't, and then you'd be penalized. And for your Part D prescription drug coverage, they would take every month that you should have been enrolled in a drug plan and you weren't, and they would tack that onto future penalties.
Hmm.
So
Okay.
yeah, so it's very important that you get that right. So that would be
Right.
the first one, right? And we don't see a lot of that. Although lately, I feel like I have been seeing a lot more folks with HSAs, health savings account, and the
Hmm.
high deductible account.
Yeah.
So
Well, one of the things is we work with a lot of folks who will move into retirement in their late 50s or early 60s, and they'll be filling a gap there.
mhm,
Frequently they get past the time where they can cobra their coverage out of work, and so
mhm,
now they're going to a state exchange. But
mhm,
one of the things you taught me is that the state exchange is not creditable coverage, if I recall
mhm.
correctly. Correct?
Correct, correct.
So which that was, it's not as blowing to me today. It was really mind blowing to me the first time you said that. So let me get this straight: the state exchanges that they force us to be a part of are crappier coverage than Medicare is, which
Correct,
basically means that his creditable coverage basically means is at least as good as Medicare or better. And
correct.
so the state exchanges are actually crappier coverage than
Mhm.
Medicare is. So,
Correct. Yeah,
okay.
so state exchange is not creditable coverage. Typically, COBRA is not creditable coverage.
Oh,
So if
wow.
someone
Okay.
is on COBRA, they'll want to enroll when they turn 65. I had another one in my head too, but that's, so those are some of the big. Oh, or if you work for an employer and you have under 20 employees,
Okay.
typically that's not going to be creditable coverage and you'll have to enroll in completely in Medicare.
Okay. Okay.
Yeah,
So
so the
you would peel off of the employer plan at that stage then.
Possibly. So, Wayne, this is where it gets so complex because then other questions I would ask would be, do you have a spouse that is on your coverage? Right. So, if someone has a spouse, it actually sometimes in that scenario, it might be better to sign up for Part A and Part B and then have the work coverage as well. Right. So, there'd be a coordination of benefits because if your spouse has to leave the work plan because you're going on to Medicare and you leave the work plan, then whatever this the spouse might end up paying $7, 8, $900 per month for
Hmm.
their coverage.
Right.
So there's so many different moving parts. So that's another question that I would ask in that scenario. If they don't
Okay.
have creditable coverage, they might want to enroll in A and B, and then just so the spouse could still have their coverage.
Gotcha. Okay.
So that
That's
was
good.
so I gave you 3 different scenarios. So the one
Yep.
is, so do nothing if you have the HSA, but you have creditable coverage. The second one is a lot of people do choose to just enroll in Medicare Part A only, and that would be if you have creditable coverage and it's not an HSA, then you could sign up for Medicare Part A and then just wait for everything else. And
Okay.
then the other one, the third option would be if you don't have creditable coverage, like we talked about, then you want to sign up for Medicare immediately when you're eligible.
Right.
And again, there's a lot of moving parts, very complex way. And so that's something that, I help folks all day, every day try to
Right.
navigate.
And you've used some letters there, ABD.
Okay. Yeah.
So maybe a quick layout of ABD,
Gotcha.
um,
Gotcha.
or
Yeah. There's a lot
DEF
more
or
than that.
whatever it's going to be.
Yeah, yeah. Yep, so essentially part A is going to be your inpatient hospital benefit. So a lot of people choose to pick up part A in the beginning because there's no premium for it as long as you've worked for 10 years and you're paying into Medicare.
Okay.
You're not going to pay a premium for part A. And again, that's your inpatient hospital. That also covers skilled nursing facility if you need to go to a rehab center. So that's covered under your part A. Part B is going to be your outpatient benefit, right? So doctor's appointments, lab work, durable medical equipment if you need crutches or a wheelchair, that's covered under Medicare Part B. Now
Okay.
there is a monthly premium for Part B. This year, the standard premium is $174.70, but that is adjusted based on your income. So
Right.
Medicare, or Social Security will do a 2-year look back on your tax return. So, if you're going on to Medicare in 2024, they'll look at your 2022 tax return to determine your Medicare Part B premiums.
Right.
But,
And you and I have had some other conversations about that. If we're doing financial planning and we're doing Roth IRA conversions and some things like that, that can drive up the income and therefore drive up the Medicare premiums. So,
correct.
yeah. So,
Correct. Correct. Um, yeah, and there's a lot more that we could get into that, but that's kind of the basic, so Medicare Part A and Part B is what you get when you get your Medicare card, right? So those are given to you by the federal government, and from there, then you have some decisions to make.
hey,
So
let me jump back just for one
please,
second. You said that you qualify for Medicare Part A, Medicare, you qualify for Medicare if you've got 10 years of creditable of credible work history. That kind of correlates with Social Security's 40 quarters. Um, but
hmm
we run into some situations where one of the spouses doesn't have 40 Social Security quarters.
hmm
So therefore, they wouldn't have 10 years of work history. How does that work for a spouse that doesn't have the work history in terms of eligibility? Are they
hmm
eligible because their spouse is eligible, or like how does
they
that work?
are. That's correct, and that's a great question. So you can use your spouse's working credits
Okay.
for your Medicare Part A.
Okay.
Yeah, great question.
Good.
With all these things, there's an infinite number of things we could talk about, with each, but so that's
Right.
so I refrain. But yeah, great question.
That's
So
good.
you can use your spouse's working credits.
Good. And I apologize. I interrupted you. So let's kind of pick up and, and move
No,
forward
that's
if we can remember where we were.
sure. Yeah. So we're talking about once you get your Medicare card that has, your Part A and your Part B, then you have some more decisions to make, right? So Medicare is essentially an 80-20 coinsurance where Medicare pays 80% of your medical, and then the remaining 20% is your responsibility. And there's no cap, there's no max out of pocket with Medicare, which, surprises a lot of us who are used to having work coverage where maybe you have a max out of pocket of, $16,000 for your family or something along those lines. But
Right.
we're used to have it, but there's no ceiling with Medicare. So, what a lot of folks choose to do from that point is to keep original Medicare with the government and then add on what's called a Medicare supplement policy. And these are policies that are offered by private insurance companies. We have several that we work with that we're contracted with. But essentially, what they do is they pay secondary after Medicare pays. So Medicare will pay the 80%, and then that 20% that's left over, that's your responsibility. The Medicare supplement will pay either a portion or the entirety of that, of those medical bills.
Okay. Okay.
So it's
And that's where you get into. So that's the Medicare supplement insurance. So that's where you're getting into. Those companies have different products or different insurance products that cover different constructs of care. Am I understanding? Am I wording that correctly?
so
Or is it just,
sort of well.
hey, they just pick up the 20% that's left?
So the coverage is standardized. So they pick up the 20% that's left, but it really depends, and that's why I kind of phrased it as they pick either a portion or the entirety of the medical bill, because it
Okay.
does depend on what supplement, right? So you can have Plan G, Plan N, Plan F. Those are the ones that really folks do nowadays. Would be those three.
Okay.
But the coverage is standardized, right? So your Plan N with insurance company A is going to be the exact same coverage as Plan N with insurance company B. The
Right.
coverage is all standardized, so it's very easy to compare in that regard. The only difference is the premium that the insurance company is allowed to charge.
Okay. Okay. Good. So those companies then are kind of you're going to get the same Plan G benefit and premium regardless of the company, or
The
is the
premium will
premium
be
going to
different.
premium
So,
will be different?
yeah, so
Okay.
we'll say, the insurance, and they look at their, loss ratios and things like that. But,
Right.
ultimately you'll look and you'll say, okay, well, insurance company A, yeah, I should stop using that phraseology because that's kind of confusing. Insurance company number one, right, is giving me a Plan G supplement for $130 per month, but insurance company two is giving me a Plan G supplement, same coverage, for $155 per month,
Right. Okay.
right?
So that's
So
where, and that just means insurance company two has either had adverse claims or something like that, where they're having to increase their premium to cover their losses.
mhm,
So,
correct,
okay.
correct. Yeah, and so, we first I filter and make sure that we're looking at A-rated companies. We wanna make sure they're financially stable.
Right.
Another thing we do is look at the history of rate increases. But then from there, if all things being equal and company 1 is offering the same supplement as company 2 for $30 cheaper, then, it might make sense to go with the cheaper one.
Sure. Right.
Yeah.
No, that's good. And then, so that's A and B and supplement. D is the drug benefit, right?
Correct, correct. So then you'll want to add a standalone prescription drug plan as well. Those are offered by private insurance companies, and those are going to be based on the medications that you're taking,
Okay.
right? So
So
pretty big.
that's when you bring, and that's where people may get caught if they, let's say they sign up. By the way, we're gonna push this podcast episode out mid-September because open windows starts. Jason, what date?
So the new plan information comes out on October 1st, but you
Okay.
can't make plan changes until October 15th.
Okay. So open enrollment starts October 15th and runs for how many days?
Well, it goes until December 7th.
Okay. Okay.
Mhm.
So you've got about, roughly a 45 to 50 day window there, maybe a couple more days than that. But you've got that's your open enrollment, and that comes up every year, and that's why it's so crucial to be having these conversations in August and September because I guess the plan information isn't out until August or October 1st. Is that what you said? So
Correct.
so literally October 1st is when the new information comes out. So man, running your business must be worse than running a CPA practice where everybody's got to file their taxes on April 15th. New information, new rules, new premiums come out on October 1st, and you've got a 50-day window or 52-day window to jam all of those decisions into, and talk to every client within that window and help them make a great decision. So that's
We Yeah, I mean, I'll just put it this way. My birthday is in November, and it's been years since I've celebrated
right.
my birthday. It's just,
Celebrate that. Yeah. Celebrate your birthday at Christmas.
yeah, yeah, yeah. I mean, it's a 7-week period where millions of beneficiaries all have a lot of decisions to make.
Right.
So, with the Part D drug plan, that's something that you want to renew or review every year, and you can make changes every year. A lot of people don't know this, and some of the laws are different in different states. But with Medicare supplements, you can make changes at any point throughout the year to a Medicare supplement. You don't have to wait till till the Medicare open enrollment. The only caveat is you have a Medicare supplement open enrollment window when you're first eligible, when you first enroll in Medicare Part B. So you could sign up for any Medicare supplement you want without having to answer medical questions. But then
Right.
outside of your Medicare supplement open enrollment, to go from one supplement to another, you do have to answer medical questions and qualify medically.
Okay.
But that
Does
can be
that
any point throughout the year.
does that go away during open enrollment? So if you have a dramatic change in health, so any change in supplement after the first year,
After the first 6 months.
Okay. After the first 6 months. So after the first 6 months, anytime you're going to do a Medicare supplement policy change, you're going to have to go through some kind of medical underwriting.
Correct.
Okay. Okay.
Correct.
What if let's go all the way back to the beginning of the conversation then. If you've got creditable coverage and you don't sign up when you're 65, is it the first 6 months after you sign up, or is there, so if I don't like if I've got creditable coverage till I'm 69 and now I'm signing up for A and B and D and I'm buying a med supplement policy, do I get a window there where I don't have to answer questions, or am I answering questions?
You do. So it relates to when you pick up your Part B. So
Okay.
if you delay enrolling in Medicare, if you sign up for Part A when you're 65 and then you don't sign up for Part B until you're 70, the second when you sign up for your Part B, that's when you have that open enrollment window for the supplement as well.
Okay. Okay. This is all really good stuff, Jason. I appreciate you letting me. I learn so much every time you and I are having these conversations. So
yeah, my pleasure.
I'm
So,
grateful.
and Wayne, another thing that you'd have to look at too, if you did that, so you'd have your Medicare from the government, you'd have your supplement, you'd have your drug plan, but then also you'd have to consider, do you want a coverage for routine dental and vision, since those are not covered by Medicare. So that
Right.
would also be a separate policy. So if you wanted to have really full coverage in that regard, you'd have basically 4 different policies that you're navigating. You'd have your Medicare, your supplement, your drug plan, and your dental and vision.
Right. And you've got a 50-day window to pick all this stuff, and you got to get a hold of you either have to figure out how to learn all this stuff in that 15-day period and make your own decision. I vote for calling somebody like Jason Lawman.
Yeah.
So
Me too, Wayne. Me too.
Of course. So Jason, I really appreciate the primer here. Let's move on, because you and I have had some conversations and dialogue about some potentially radical shifts in the landscape that are pending over the next 1, 2, 3 years.
True.
And some of this is some of it we know a little bit about, but a lot of it is still in flux. And as with lots of government regulation shifts, there's stuff in the courts now and all that kind of stuff. So can you walk us through some of that?
I can, Wayne, but if I may just really quick go back to our other
Of course.
topic.
Yeah.
Because, in terms of the Medicare options, we talked about original Medicare and a supplement. The other side would be Medicare Part C or Medicare Advantage plan, right? So that's another option. And, actually, I saw a pretty shocking statistic that at this point, I think nationwide, 54% of Medicare beneficiaries are actually in a Medicare Advantage plan instead of original Medicare. At this point. So it's becoming a lot more popular. So really quick with your Medicare Part C, those are those bundled plans where, you have your hospital, your medical benefit, your drug benefit, everything is coming from one plan that's coming from, that you get from a private insurance company.
Okay.
Yeah. And so those would be something else where every year during open enrollment, you'll want to review your coverage and then, and we'll make changes.
Okay. And that's a situation where, like you said, you'd have one plan, not 4.
Correct.
So it streamlines things. Now you've got to get into the minutia of each company's plan and each company's construct and how that lines up with your specific needs. And that's what Nexus is all about.
Exactly. Those plans are not standardized. And so, there's a lot that you have to look at. You've got to consider the network. Are your doctors in network? Are your medications covered under this plan? What are the ancillary benefits that they're offering? Things like that. So, but when we talk about the changes that are coming up in 2025, it's important to know the distinction between the original Medicare and a supplement and a drug plan versus Medicare Advantage.
Okay. No, that's good. Appreciate that. So what are the changes coming to 2025?
Great question, Wayne. Happy you asked. So there's a lot. And, I will say, at the time of this recording, this is what we know. So on August 16th, 2024, things are changing rapidly. So, this podcast would have been very different 3 weeks ago than it is today. So please keep that in mind. But here are the changes that we know so far. So the first one, and I will say too, they're all very positive at this point. There's always going to be some unfortunate, unintended consequences with some of these decisions, but I think they're all very positive. So the first one is they're actually
Positive and government regulation don't seem to go together in my mind, Jason, but I'm going to take your word for it and
yeah.
act on faith here. I'm listening with skepticism.
Agreed. As well as you should. As well as you should. But so the first one would be that there's now going to be a $2,000 cap on drug spending for the Medicare beneficiary. So
Hmm.
whereas before, there was 4 different stages of drug coverage, and once you get to 8,000, then you hit your catastrophic coverage, and you don't pay anything else. So this upcoming year, starting next year, there's going to be a $2,000 cap,
Hmm.
which is great because I have a lot of clients who take 10 or more medications, and it's very, very good to have the $2,000 cap.
Right. Right. That means though that those insurance companies have got to do they get to raise the premiums? Because I mean, if you're saying the old cap was 8,000 and the new cap is 2,000, that says to me that the insurance companies are eating $6,000 more per person risk, and you can't do that for free.
Yeah. Yeah. Well, it's a great question. And so this is where it kind of becomes, this is why it's better now than when we originally scheduled this, because initially it was going to be the responsibility of the insurance carrier to try to figure out how to implement the $2,000 cap. So, we had looked at plans, we thought the premiums were going to be doubling, tripling, things like that, because initially the government wasn't going to subsidize the plans more. They were basically just going to say, okay, well, carriers, you'll have to figure it out. Now, that's not going to be the case. So the carriers are, well, on the standalone prescription drug plans, the government has decided that they randomly found a bunch of billions of dollars that now they're going to use to subsidize these Medicare plans. Because, when CMS was getting the bids for 2025 from the carriers, they were coming in, from what I understand, triple from what they
Hmm.
were this year. Plus, not only that, but a lot of carriers have already said that they're not going to offer plans in 2025. So
Okay.
CMS realized, hey, it's an election year. We have to figure something out, right? Oh, here's billions of dollars we can throw at Medicare.
The
So
timing on this is so the information's supposed to come out October 1st. The plans open October 15th, and voting is first week in November.
yep.
That would be an October surprise, wouldn't it?
Yep.
So,
Yep.
hey,
Exactly.
everybody over
Exactly.
age 65, your premiums for drugs are tripling.
hmm
Vote
hmm
wisely.
Yep.
So-
Exactly. So,
wow.
thankfully, so they are now, I mean, really, they're kicking the can down the road, right? Because, Medicare, I mean, and Wayne, you could speak to this more. I'm not an economist, but I know that that's one of the big line items for our country, and the debt and all that.
Yeah.
So now we're throwing probably hundreds of billions more at Medicare at this point,
Yeah.
kicking the can down the road. But in terms of, my clients and your clients for the next year, it's actually going to be a better outlook for them, thankfully.
Okay.
Now,
Good.
I do expect the plans to go up. That being said, I don't expect them to go up, in multiples of, 2 to 3 times like we were originally thinking. But I think most beneficiaries, their plans will go up. I think we'll see other unintended consequences too. Like I think that, probably formularies are going to tighten up a lot. At
Mhm.
this point right now, not every drug plan is required to cover every medication,
Right.
right? So every drug plan, they're required to cover 2 medications in each therapeutic category.
Okay.
So, I think that the carriers are going to tighten that up a lot, and offer less
Right.
drugs on the formulary. Um,
Okay.
so that's one thing we'll see. And actually, to go back to the other kind of discussion on the $2,000 cap, why that's so important is in order to count towards the $2,000 cap. So that does not include drugs that are not on the plan's formulary. So if
Mm.
I'm enrolled in a Part D drug plan and I'm taking a drug, say I'm paying $100 per month for a 30-day supply and it's not on the plan's formulary, that money that I'm spending is not counting towards the $2,000 cap.
Gotcha.
So it's
Okay.
very important for people to know. It's very important that, you run your drugs, before you enroll in the plan. You check to make sure that your drugs, your medications that you're taking are on the plan's formulary.
Yeah, but think about this from a business model perspective, though, on behalf of these companies. So the government says you're going to have to drop your spending, the max spending per person from 8,000 to 2,000. Then they come back. So the insurance company is like, oh crap, we got to take on $6,000 more risk per participant,
Hmm.
um, which also opens up the threshold for as a patient. So you've got patients who can't afford to spend that $6,000, and now they're going, yippee! I can get my coverage. I can get my drugs, and which you want people to be taking the drugs that they're prescribed, right? You want people to be compliant with their doctor's instructions,
Hmm.
but a lot of people, especially seniors, don't have the money to cover that $2,000 to $8,000 window. So now you're going to get hopefully more compliance, but the insurance company still has to, okay, great. You're going to get better adaptation, better compliance with people taking the drugs they're prescribed, which means the person is only going to be out of pocket $2,000. So but that also raises the risk that they're going to run over the $8,000 limit too, which flips back to the insurance company. So even though the government came back and said, "Oh no, just kidding, we're going to cover the $2,000 to $8,000 limit," you've still got people who are now going to be complying and taking all of the drugs that they've been prescribed.
Hmm.
And because they're only $2,000 out of pocket, then the government's going to pick it up to 8, but then the insurance company's still on the hook for everything over 8.
Hmm.
And so the insurance company's actuaries still have to figure out, hey, how many people, how is this going to affect our spending?
Hmm.
And that's like you said, that's where it comes in, to limit the formularies and that kind of thing. So because if they can push some of that off formulary, then
Hmm.
they don't end up having to cover it.
Yeah.
So
Yeah. The other thing would be step therapy too. I mean, that's another way that the drug companies control their costs. So, your doctor might prescribe you a medication and your insurance company might say, well, yeah, that's a little expensive. So we want him to try this really cheap generic first. And,
right,
we'll see if that
right,
works. Hopefully he doesn't die. And then,
right,
after using it for however long, then we'll pay for this other more expensive drug.
right.
So, step therapy is another thing, prior authorizations. I think these are all going to be utilized a lot more.
And I'm
Yeah.
100% sure that the insurance companies are hiring competent and experienced physicians to make the recommendations for the step therapy and the length of time, that as opposed to hiring a bureaucrat and a bean counter whose primary concern is protecting the profitability of the insurance company. Because that's never happened before in history, where we hired a bean counter to make medical decisions and they can't, and we got an unanticipated negative outcome. And
I'm,
please hear the sarcasm
yeah.
dripping as I'm saying these words.
No, I'm sure I'm sure they're finding the unicorn actuarial physicians out there, right?
Right, right, yeah. So,
um,
yeah, the intersection of math and medical practice. Yeah,
yeah.
that's
Yeah. And so actually, Wayne, so we're talking about the changes that are coming up. So that's only one, right? The $2,000 cap, which is great.
right,
The other one is the elimination of the donut hole or the coverage gap, right? So we won't get into all the specifics. There were four different stages of drug coverage within Medicare. That's going away. Now there's only going to be three. The donut hole, in which the member would have to pay 25% of the retail cost of their medication until they reached a certain amount. Now that's going away completely, which is,
okay,
I mean, also great news for people on things like Eliquis and very expensive medications.
mm,
So
okay,
again, that's very positive. The other thing that they're doing is CMS or the Medicare. They're going to do something called a payment plan. So what would happen a lot of times with a lot of the plans, the standard deductible, which is the amount that you pay out of pocket and before the insurance picks anything up, the standard deductible next year is going to be $590. So for a lot of seniors who, unfortunately, they're only income is, maybe Social Security, they're making $1,700 a month, maybe a little pension, they're going to go to the pharmacy on January 1st and have to, at the very least, satisfy a $590
Mm,
deductible, which
okay.
is very difficult for some people,
Sure.
right? So what Medicare is doing, they're going to have this payment program where they're going to take the payments, and basically you'll be able to pay monthly for your medication. So, for someone who takes a lot of expensive medications and they anticipate that you're going to pay the $2,000 for the year, then they'll just take 2,000 divided by 12, and that's what you're going to pay monthly for your
Mm,
medications. It's a
okay.
very new program. Apparently, it's not going to start until January 1st. You'll be able to opt in at any point throughout the year. People have brought in, up a lot of questions. There's a lot of challenges to it, but again, ultimately, as it sits, I think it's very good. We'll see how it actually ends up working out, but
I have
I think it's
about
very positive.
47 different questions about who has my data and what data do they have on me and how is this violating my rights to privacy. But that's a topic for a different podcast. So,
Sure, sure. But yeah, I mean,
okay.
we're going to start coming out with a lot of content about this.
Okay.
So, for all of your, clients, people who are going to see this, on Nexus Insurance Advisors, I would think in the next few months, we're going to post a lot about, you know,
Good.
how to access this information, things along those lines.
That's a good segue. Are you on social media is Nexus on social media? Give us a couple of, tags and things that we can, people should look up.
Yeah, thank you. I mean, so we're on Facebook. So Nexus Insurance Advisors. If you just go to Facebook, you'll find us. Same thing with a LinkedIn. We do post pretty regularly. We have
Okay.
a YouTube, but please don't check it now. Maybe wait till September 15th. We'll have some more content up.
Okay. Okay, good. And that's about the time we expect to get this episode out. Jason, so there's big changes coming. Sounds like the government is kind of headed off some of the massive premium increases that we were expecting as recently as a few weeks ago. I'm sure there's there's court cases and all this kind of stuff that's going on, and some of this stuff as well.
Mhm.
Um, any other major changes that we should be aware of kind of coming into fall of 24?
Not necessarily. I mean, again,
Okay.
there's a lot we could talk about. There's questions of, that creditable coverage that we talked about in the beginning of the
Right.
episode. There's questions of, well, next year, plans that were considered creditable, are they still creditable now? Are they
Mm,
still as good as
right.
Medicare? And
Okay.
basically, I think CMS kind of forgot about that whole piece. And they
Okay.
basically just came out and said, look, for next year, if it was creditable this year, it'll be creditable next year. I think that's going
Okay.
to turn into a nightmare in 2026 and beyond.
Okay.
But in terms of 2024, I mean, so those are the real changes, the $2,000 cap,
Okay.
and all this is not even just the regular changes that happen
Right.
to your Medicare plan when you
Right.
go from one year to another, right?
Right.
So, I think it's very important especially if you have one of those Medicare Advantage plans that we talked about, where you're getting all of your benefits from a private insurance company. uh, you know, a lot of the subsidies that we talked about on the drug coverage side are only for the standalone plans. So with the
Mm,
Medicare Advantage plans, they're already heavily subsidized, but they're going to have to eat some of that cost for the drug, for the
mm,
new caps and everything. So I
right.
think with those, you'll want to check the summary of benefits. You'll want to make sure that there hasn't been a reduction of benefits year over year from your plan from one year to the other. You
Okay.
know, because they can hide those things, right? With a Medicare Advantage plan, it might look like the same plan, but they might give you, maybe to compensate for how much they're going to spend in drugs, they might give you less dental coverage, right? Or
Right.
they might up your hospital copay.
Come
So
on, Jason. An insurance company would never hide something from the insured. They
no
provide
comment.
that information in clearly articulated lawyer speak in the fine print on page 39, paragraph D, subsection I.
Hmm. Agreed, but also no comment. If you're a carrier and you're listening to this, we love you guys. We're happy that we represent you.
Jason's your friend.
Most.
I'm the skeptic. So
Yeah.
all good. Now, Jason, this has been really helpful. Thanks so much for your time today. And I know this is going to be something that is really valuable for our listeners. And it's valuable for folks who are 65 and over because it directly impacts them.
Mhm.
It's healthy for the people who are in their 50s, the people who are in their 40s who have parents who are approaching this, or who are maybe mom and dad are coming and saying, "Hey, can you help me with this?"
Mhm.
Because I know that having a resource like you, like your team at Nexus, being able to outsource that and just say, "Hey, I don't need to learn all this. I just need to have a contact and be able to get mom and dad the help and assistance that they need,"
Mhm.
is really, really valuable. So thank you for your time today. Jason Lamadou from Nexus Insurance Advisors.
Thank you for listening to the Envision More podcast with Wayne Wagner Jr. of Vizionary Wealth Management. We hope you were encouraged and inspired by the conversation today. If you want to dig deeper into the show notes or Wayne's work at Vizionary, you can find us at envisionmore.com. That's Envision with a Z. Advisory services are provided through Wealth Plan Investment Management. Wealth Plan Investment Management and Vizionary Wealth Management are separate entities. The content is developed from sources believed to be providing accurate information. The information in this material is not intended as tax or legal advice. Please consult legal or tax professionals for specific information regarding your individual situation. The opinions and material provided are for general information and should not be considered a solicitation for the purchase or sale of any security. Thanks for listening.